This is chapter 21, the neurologic system. The nervous system is the body's internal communication network. So it coordinates all body functions and all adaptations to changes in the body's internal and external environments. Because of its intricacy and complexity of the nervous system, neurologic impairments can manifest in many different ways. So the functions of the nervous system, it has a sensory function, an integrative function, and a motor function. So when we talk about sensory function, it senses things that the body feels inside and outside. Say for instance, I stick myself, and so the nervous system helps you to sense that you have stuck yourself or you've burned yourself or something like that. Integrative function, so it can interpret the sensory input that comes in. So I stick myself, the brain interprets it as pain and then makes a decision on what needs to be done. Motor function, it also has a motor function. The brain says that's painful, I need to remove that painful stimuli. Or, I burn myself. The brain senses it and interprets that as painful and sends a message down to my hand, remove your hand from that hot surface. So those are the functions of the nervous system. So this slide just basically reiterates what we just discussed in the previous slide, with the central nervous system being divided into central nervous system and peripheral nervous system. Of course, with the central nervous system containing the brain and spinal cord, which are the command centers, excuse me, to interpret sensory information and send back out commands to the body. Whereas the peripheral nervous system contains all the peripheral nerves and cranial nerves in the body, which helps to get messages to the central nervous system and back down from the central nervous system to tell the muscles or the glands what they need to do. Okay, so I don't want to get into an anatomy and physiology lecture here, but we know the brain has different divisions that provide different functions. So we have the cerebrum, which receives and interprets all the sensory information coming to the brain and helping to control all voluntary movement and some of our involuntary movements as well. So if we have areas that are impaired from the cerebrum, then we might have impairment with our thinking, our language abilities and learning abilities and things like that. Our cerebellum is responsible for like coordination and posture and muscle tone, things like that. So if you have an impairment in that area, you may see a patient experiencing some dizziness, might have so they might of course be at risk for falls, things like that, because their balance is off and maybe have some weak muscle tone as well. Diencephalon, that helps to direct senses throughout the body, such as your hearing, your vision, smell, taste, all those type senses as well. And it does control some of your endocrine functions as well as motor functions as well. Okay, so I don't want to get into a anatomy and physiology lecture, but of course we know the brain is divided into several areas, and if one of those particular areas is impaired or damaged, then we could have certain impairments that we'll see in our patients. So for example, we know the cerebrum is where the brain receives and interprets all the sensory information, which we had just discussed, and then controls the voluntary movement and some of the involuntary movements as well. So if a patient has some impairments in some portion of the cerebrum, they might have difficulty thinking or learning, or even some language impairments or things like that. The cerebellum is what controls our movement, our balance, our posture, our muscle tones, and things like that. So if we have a patient that has impairment in this area, we might see some imbalances. They, of course, probably would be at risk for falls, maybe some dizziness and things like that because they're off balance. So we want to watch them for that. The diencephalon is which helps to direct, all of our senses throughout the body. So our hearing, vision, smell, taste, touch, perception, all those type perceptions. It also has some functions in controlling the endocrine function, as well as our motor function. There's actually a great table on page 473 of your book, table 21.1, that helps to outline the various functions of these divisions of the brain. So the thalamus serves as the relay center for sensation. So relays information between the spinal cord and the brain. If you have an impairment, in the thalamus area, you might experience some numbness of some sort. The hypothalamus controls a lot of things here. Our body temperature, our blood pressure, sleep-wake cycles, appetite and weight control, emotions, sexual behavior, things like that. And so if we have some type of impairment in this area, we might experience, or our patients may be experiencing some weakness or dizziness, even some emotional problems they might have. So, and the brainstem contains 3 parts: our midbrain, pons, and the medulla oblongata. So these things control various, things. Our midbrain controls our visual and auditory reflexes, whereas the pons helps to regulate our respirations. The medulla oblongata, it controls a variety of things such as our heart rate, respirations, blood pressure controls, and things like that. Even coughing and sneezing and things like that. So if we have a issue in this area, we might notice a lot of different things. You might have some issues with excessive sweating or whatnot in those issues. Again, these things are also outlined in that table that I described in the previous slide on 473, table 21.1. So this slide just goes into a little bit more detail about the midbrain, the pons, and the medulla oblongata. It kind of shows you which cranial nerves are in each area. So once we learn our cranial nerves, then it will make more sense. You'd understand why certain things are happening if there's an impairment in the midbrain, or if there's an impairment in the pons, or if there's an impairment in the medulla oblongata. So we will, several slides down, we'll have discuss our cranial nerves. But I also posted a video to Blackboard for you to view regarding your cranial nerves. It might be a great way to help you. It provides some mnemonics for you to try to remember the various cranial nerves and what they're for. So one very important point that you want to remember is the left side of the brain controls the right side of the body, and the right side of the brain controls the left side of the body, so it's opposite. So this is meaningful because if you were to have damage to the left side of the brain, then your right side of your body would be affected, and vice versa. So for example, if I had a left side or a stroke, a left hemisphere stroke, then I might be expecting some weakness or paralysis to the right side of the body, and vice versa. If I had a stroke to the right hemisphere of the brain, then I might expect some weakness or paralysis possibly to the left side of the body. So make sure you remember that point. It's opposite. The left side of the brain controls the right side of the body, and the right side of the brain controls the left side of the body. So when we're talking about neurological concerns, one very important factor you want to remember is assessing that person's level of consciousness. That person's level of consciousness will be can be a very early indicator of the person's brain function. You'll see when we start to talk about some of these diseases, if a person's level of consciousness is decreasing, then that's a good indicator that their condition may be worsening. If they're getting more sleepy, if they're getting, going into a stupor, or if they're getting agitated or irritable, behaviors changing, things like that. So we always want to, when we're doing neurologic assessments, assess that person's level of consciousness and is it worsening. So two things we're going to assess when we assess a person's level of consciousness. We're going to assess their level of arousal, and then their orientation status. And so we'll talk about that on the next couple of slides. All right, so different levels of arousal for our patient when we're talking about our levels of consciousness. So first, alert. So this person just responds fully and appropriately. You say their name and they're able to respond, no confusion or anything, so they respond fully and appropriately. A person that's lethargic, they're going to sleep a lot of the time, but you can wake them up easy. You can arouse them easy. Maybe you call their name or whatever. But and then when they do wake up, they respond appropriately. They're not confused or anything. They're just very, very sleepy a lot. And so then our next one is obtuned. So obtuned, our patient that's obtuned, we might have to use some non-painful stimuli to get this patient to wake up. So we might have to shake them a little bit, but not applying any pain to them, just using some non-painful stimuli. But when they do wake up, they're probably going to be confused, and then they're going to fall right back to sleep after you have your conversation or whatever. Stuporous. So this patient, we have to use some painful stimuli to wake this patient up. They don't wake easily at all. We got to put some pain, apply some pain to get them to arouse. And then comatose, of course, there's no response at all with this patient. Okay, orientation. So we're going to assess person, place, time, situation when we're discussing orientation. So we're going to ask this person different questions to determine if they're oriented to each of these areas. So person, does the person know who he or she is? Place, does the person know where he or she is? So, person, my name is Mrs. Sadler. Place, I'm here at Bryan and Stratton College. Time, do they know, do they know the day? Do they know the year, or whatnot? Situation, do they know why they're in the hospital? Do they know the situation, what's going on? Do they know why they're there? So if a person is alert to all of these areas, we'll say alert and oriented times 4. So say a person's not alert and oriented times 4. If the person is alert and oriented times 2, then we need to say, which 2 it might be. So alert and oriented times 2, person in place or whatnot, whatever the 2 they were oriented to. So, who's ever reading your documentation would know. Okay, so now we're getting into our cranial nerves here. So with our cranial nerves, like I said, I posted a video to Blackboard. It would be probably very helpful to you to take a look at that video, because you will need to know your cranial nerves. You need to know the function of them. Some cranial nerves are have sensory functions. Some cranial nerves have motor functions. So sensory, like your senses. So this cranial nerve 1 is a sensory because it one of the function is smell, which is one of your senses, right? So you need to know what the function is. You need to know the pathology. So the pathology means if that cranial nerve is affected, what are you going to see in your patient? What's the issue going to be with your patient? So take a look at that video, because it provides, like I said, some mnemonics for you to, help you learn, all 12 cranial nerves. So cranial nerve 1. Oh, and the other thing, you need to know the name of it. So olfactory is cranial nerve number 1 is, we need to know that's olfactory. Because you could be asked, the question might say cranial nerve 1, or the question might say olfactory. So you would need to know both of them. So this is a sensory nerve, and the function is smell. The pathology, meaning what will happen if this nerve is affected, is anosmia. Anosmia simply means they can't smell. If the function is smell, they can't smell if it's affected. Cranial nerve 2 is your optic nerve. This is also a sensory nerve. So the function of this one is vision. And so vision, of course, if the nerve is affected, then blindness, the pathology could be blindness, papilledema, swelling of that area, double vision, or some visual field defects in this cranial nerve if issues were to occur. So cranial nerve number 3 is the oculomotor nerve, and just as it says, oculomotor, it's a motor nerve, and so it controls eye muscles. It helps to move the eye inward and up, and help with the eyelids, and it also constricts the pupils. So if we had issues in this cranial nerve, the person might have diplopia, which is double vision, or ptosis, like drooping eyes or things like that, fixed dilated pupils as well in this area. Cranial nerve number 4 is the trochlear nerve, and that's also a motor nerve. And so the function of this particular nerve is it moves the eye down and out. So if there's an impairment with this cranial nerve, then the patient would have an impairment in their downward gaze, so they'd have difficulty looking down. Okay, cranial nerve number 5 is the trigeminal nerve. And so the trigeminal nerve has both functions, actually, motor and sensory. And so this is the one where it helps with chewing, function of chewing. And so which would be known as your masseter muscles. It provides sensation to the jaw and sensation to the cheeks and the upper lip and nares and all those things as well. Sensation to the forehead, different areas of the face as well as the chewing mechanism. And so if there was an impairment in cranial nerve number 5, this person would obviously have probably difficulty chewing, some, weakness in their jaw or whatnot, and difficulty with sensation to the facial area. Cranial nerve number 6 is abducens, and this is a motor nerve. So the function of abducens is to move the eye laterally. So if there was an impairment in this cranial nerve, then the eye would turn inward. And also patient may have some double vision with this cranial nerve impairment. Cranial nerve 7 is the facial nerve. This also has motor and sensory functions. So the facial nerve actually controls the muscles of the facial expression. So your facial expression, which makes sense, facial nerve, facial expressions. And it also controls a portion of the taste to the tongue, salivating and tearing up type things. If there's an impairment in this cranial nerve, one key indicator, it's called Bell's palsy. So with Bell's palsy, it's like a temporary facial weakness. If you see a person with Bell's palsy, you might think they're actually having a stroke, because that's what it, would kind of look like with the face. If you've ever seen a person having a stroke, you see that face weakness and drooping on the side. So it is temporary. They will eventually, most people tend to, gain their facial structure back. But when you look at the person, it does, look almost as if they are having a stroke with Bell's palsy, if there's an impairment in this facial nerve, cranial nerve 7. So cranial nerve 8 is the acoustic nerve. It's a sensory nerve, but you also might hear it called vestibular cochlear nerve as well. So either or, you might hear it, stated each way, acoustic or vestibular cochlear, but it is cranial nerve 8. And so the function is hearing. The function is hearing and your equilibrium, so your balance. So if you have some issues with this cranial nerve, you might have difficulty hearing, or have some tinnitus, which is ringing in the ears, or vertigo, some type dizziness or something like that, because your equilibrium may be off. Cranial nerve 9 is glossopharyngeal nerve, and it also has some motor and sensory functions. So this nerve is responsible for swallowing, your gagging, and then also taste on a portion of your tongue, as well as sensation to the pharynx. So if you have an impairment with this particular cranial nerve, obviously you're going to have some difficulty swallowing and a loss in your gag reflex with this cranial nerve. Cranial nerve 10 is the vagus nerve. So the vagus nerve has sensory and motor functions as well. So it supplies some sensations to the tongue and throat and pharynx as well, but it also is responsible for the GI tract, so functions in the GI tract. So if there's an impairment with cranial nerve 10, you might have some impaired speech or dysphagia, difficulty swallowing or something like that, respiratory problems, or some cardiac arrhythmias. Cranial nerve 11 is called the spinal accessory nerve, and it has motor functions. It's responsible for your movement of your head, neck, and shoulders. So obviously, if you have impairment in this cranial nerve, you're going to have some impairment in the movement in those areas, the head, neck, and shoulders. Cranial nerve 12 is the hypoglossal nerve, and it also has motor functions, and it's responsible for movement in the tongue and also being able to articulate your speech. So if you have impairment in this particular nerve, obviously you have some difficulty speaking, possibly difficulty chewing or swallowing, and you may even see a little deviation with the tongue in this particular cranial nerve. I have posted a video with a full neurological assessment on Blackboard for you to take a look at. So please do take a look at that, so that you are familiar with what all involves a full neurological assessment. We'll talk about in the next chapter about, a lot of head injuries, spinal cord injuries, a lot of neurological problems. So when our patient has these neurological problems and head injuries and things like that, we need to know how to do a neurologic assessment on our patients, how to assess various cranial nerves for our patients. So watch that video too, so that you make sure you understand how to complete a full neurological assessment. So as we stated, the central nervous system contains the brain and the spinal cord. So obviously we want to make sure this area is protected. The body, wants to ensure the protection of these areas. So the way it does that, you have your skull and your vertebrae, of course, which is the bones down your backside. The meninges as well. You have the three meninges, the dura mater, arachnoid, and pia mater. Meninges also help protect that the central nervous system. And you have your subarachnoid space, and then you have the cerebral spinal fluid as well. That's in those areas to help protect your central nervous system. And so when we talk about some of the disorders of the nervous system, we'll talk about how these things can be impacted. So the brain has the neurons that, help transmit information or nerve impulses. When we have areas of the brain that die from lack of oxygen. So we'll talk about, different disorders such as a stroke, where you might have a lack of blood flow to a particular area of the brain. And if you have a lack of blood flow to that particular area of the brain, then you're going to have a decrease in oxygen to that area of the brain, because the blood carries oxygen. So if we have a decrease in oxygen to a particular area of the brain, then that area of the brain will die. Once destroyed, the brain cells cannot be replaced. So, if they do die, we'll see, depending on the type of depending on the area where the damage occurred, we will see certain factors in our patient, as we'll see in some of the disorders that we will discuss. Okay, so some age-related changes as we, begin to get older in our neurologic system. Just because we get older doesn't mean we necessarily have to lose our intellectual function. Getting older does not mean does not mean everybody that's older does not have Alzheimer's or some type of neurological or intellectual difficulties. I've seen people in their 90s and even their hundreds and have great intellectual function. Of course, the chances we do lose neurons, and we'll talk about later how the brain does begin to atrophy or decrease in size as we, tend to get older. So those things do occur, but it doesn't necessarily equate to a decreased intellectual function. Also, as we get older, of course, our impulses, transmission might be a little bit slower, transmission of our impulses, so which will cause a decrease in their reaction time. So they may be slower to react to different things. So you want to just kind of take your time with them. Maybe they're slow to respond to you in certain situations. Give them time. Don't try to rush them. Let them take their time to respond to you. Or if you're trying to get them to the restroom, take your time. Don't try to rush our older patients. They might have a decrease in the blood flow to the brain as well. Decrease in their sensation, So we have to be patient and give them, a little extra time to do things and to respond to us. Some other changes that might occur as we get older. It might take us a little bit longer to respond to stress. When we're talking about memory, a lot of times short-term memory might be affected while their long-term memory remains intact. So these individuals, they could tell you all kind of things about, their past and growing up and, different things from the past. And so they don't have any difficulties with that. But if you're trying to teach them new things, maybe they got started a new medication, or maybe, they got a new diagnosis, or their short-term memory might not be as intact. And so they may forget things quicker than than they used to. So short-term memory may be affected while their long-term memory may remain intact. They may have difficulty with their balance, and so difficulty in walking. So, we have a lot of them using canes and walkers and things like that. So they could be fall risk. So, we need to, if that is the case, we want to put things in place to make sure we are preventing falls, with these individuals. Make sure your call lights are in place. Make sure you answer those call lights in a timely fashion. Make sure the bed is in the lowest position. Does this person, need assistance when getting up? And so things like that. Their reflexes may be slower as well. Their pupils might decrease. And so, like I said before, take a little bit longer to process information. So if you ask them a question, give them time to respond. Don't just quickly go on to the next question or whatnot and saying, oh, they didn't know or they couldn't answer me. Give them time to respond to different things. Okay, so the Glasgow Coma Scale. I did put a video on Blackboard regarding Glasgow Coma Scale that I want you to look at. It goes into great detail on how to complete the Glasgow Coma Scale. And so it's another neurologic assessment that we need to know how to do, but it assesses a patient's ability to open their eyes, their motor responses, their verbal responses as well. And it provides a score that will range between 3 and 15. So the higher the patient's score is, the more alert that person is. The lower the person's score is, then the closer to comatose that person would be. So a score of less than 8 would likely indicate the patient being in a coma. But like I said, make sure you go onto Blackboard, watch that video so you know how to complete that assessment as well. So as I previously stated, there's a video on Blackboard on the Glasgow Coma scale that I would like you to watch. There's also another video on Blackboard regarding decorticate posturing and decerebrate posturing that you need to watch as well. It shows you great pictures on what the person would look like if they had decorticate posturing versus decerebrate posturing, which you will need to know, as well as it discusses what areas of the brain would be affected if a person has decorticate posturing or decerebrate posturing. So please make sure you do watch that video as well.